Let me introduce our team. Our angiographic sister nurse is Miss Julia Friedrich, and the two radiographers who will help us is Constanze Kraft and Ismail Tarmoun. Dr. Fischer and Dr. Noor are here on the table. We already placed our 10 French access in the right liver vein, and we have a stiff wire, and now we will push the needle forward.
Just to mention what happened before, we go subcutaneous.
Can you just explain to our audience, because not everyone is familiar with the TIPPS implantation here. Where are you with your obturator right now? In which vessel, and what are you going to do?
What we do?
It's the right liver vein.
This is the right liver vein, and we go through after giving local anesthesia through the skin. And then we puncture the right jugular vein just to be in line with the superior vena cava and the right atrium and the inferior vena cava. So this is the main, our line, to be in line. So in order to introduce our TIPPS needle inside, which is a very stiff needle, so to be malleable during our procedure, we need to be in line with the superior vena cava as well as with the inferior vena cava and the right liver vein.
Does the patient receive any pain medication?
Yeah, of course. We give him Dipidilor, which is a sedative. We don't do the procedure under general anesthesia. It's a very the technique is tolerable for the patient. And now we did puncture of the position of the portal vein. We do routine CT scan with contrast, triphasic, just to delineate the liver veins as well as to see the anatomy of the portal vein, to decide which liver vein is suitable for the procedure, either the right liver vein,
I think it's important that you comment
vein.
that Dr. Fischer is doing the ultrasound simultaneously.
And are we able to see probably also the ultrasound image?
Dr. Noor, can we see the ultrasound image or no? The camera is
yes,
maybe.
Yes, of course. We can rotate the machine like this way, if the colleagues is going to demonstrate.
Okay.
So
I wonder. Yes. Okay.
Okay.
so oh yes. Now we see.
Yeah, it's quite difficult.
Better impression. So this is now done simultaneously.
By ultrasound.
So we have an integrated ultrasound
yes,
in the angiographic system.
Yeah.
Mm-hmm. Yeah. So Dr. Thalhammer is now again pushing the needle in order to,
just to cannulate the portal vein. And we are trying to do aspiration with withdrawal of the needle in order to be sure that we are intraluminal inside the portal vein. When we get blood suction, this means that we are endoluminal. We can do afterwards a test to show that there is flow inside the portal vein. This system is coaxial system. So we have to do the puncture by putting the stellate inside, and to remove the stellate outside to detect if there is portal, if that we are endoluminal inside the portal vein. The most successful step in this procedure is the planning. So we have to do triphasic CT scan before the procedure to determine the position of the liver veins as well as to delineate the portal vein. Some of the important steps for the preparation of the case is to be sure that there's no severe ascites, as most of the cases, most of the indications of TIPPS is refractory ascites or hemorrhage due to bleeding varices. So if the ascites is little by drainage of the ascites before the procedure, this will help much during the procedure itself. As you can see, Dr. Talama is doing rotation during puncturing the portal vein, just to keep a contact between the right lever vein and the portal vein.
Erzählen Sie mir.
Bei Ihnen alles in Ordnung?
Ja, erzählen Sie mir was.
Ja, ja.
Hey.
Ich muss nur weiter zurück. Ich kann.
If you don't mind until you will cannulate the portal vein, we will probably continue with the next presentation and then coming back with you in about 5 to 8 minutes. Is this okay with you?
It's okay.
It's okay. We tried to puncture the portal vein due to the presence of ascites as well as the angulation between the right hepatic vein and the portal vein. So it's technically a little bit difficult due to it needs more trials to puncture. We are trying also with the ultrasound, and we will get it. But of course, it depends on the time and the cooperation of the patient, as well as the how to go through the puncture to the portal vein. Yeah.
Das ist die Vena cava, würde ich sagen.
Ja.
Neu?
Spitze?
Ja,
Oder
klar.
neu?
Looks for me like the inferior vena cava.
Yes.
See this? Or
Ist die Schleuse rausgesprungen? Hm? Nee, eigentlich nicht.
Nadel?
Ja.
Oder Spitze?
Wenn man richtig kann.
Das ist ein Hof.
Herr Fischer, können Sie mal ein bisschen da helfen? Ja, wir sind schon gut. Ich kann nochmal scharf.
Mach die Spitze fertig.
I think yes, I think our transmission time is unfortunately at its end, and I think you need also your time to finish this case.